Good morning, students. Today, today we have a small topic. As I told, I'll be discussing infectious diseases and hematology. Today is another topic from infectious diseases, which is leptospirosis. Okay, so leptospirosis is one of the diseases we usually see in our intensive care settings and also in OPDs. Many of the cases go undiagnosed, but still, patients with severe disease they come and with jaundice, pulmonary symptoms and all. So we are going to discuss in detail regarding this disease. Okay, so leptospirosis is a zoonosis, okay, which is transmitted from the animals, okay. So with the protein clinical manifestations caused by pathogenic spirochetes from the genus Leptospira. So the organism is a spirochete, okay. It is transmitted through zoonosis. The mechanism of transmission is zoonosis, okay. uh, all the Leptospira are derived from the genus. All the pathogens are derived from the genus Leptospira. Okay, there are many pathogens which cause. The many subtypes of genus Leptospira which cause the disease. So this disease has severe names because this disease has been coming since a long time. So many people have called it. From different countries, they have given different names, like Weil's disease, Weil-Vasilev disease, Swinehert's disease, rice field fever, waterborne fever, Nanokayami fever, okay, and cane cutter fever, swamp fever, okay, and mud fever, Stuttgart disease, and canicola fever. Okay, so these are the names. Okay, they might confuse you in the examination, so you should be knowing. They might not be using the term Leptospira. They can use any of these diseases, since our NEET examination is famous to give these kind of questions. So they don't ask about a particular disease directly. So they might give you any of these names. Okay, and we'll give you some options regarding the disease to describe it or to answer the question. Okay, so coming to the epidemiology, leptospirosis is widespread prevalent zoonotic disease. It occurs in both temperate and tropical regions. Okay, so temperate and tropical regions, both in these regions we can see leptospirosis, and the incidence in tropics is 10 times higher than in the temperate regions. So you should remember this. In the tropical regions have 10 times higher incidence than the temperate regions. So, and various mammals are the natural hosts. Okay, humans are infected through mammals incidentally after the exposure. Okay, so the organism infects a variety of both wild and domestic mammals, especially rodents. Rodents are very important here. You should remember rodents. Cattle, swine, dogs, horses, sheep are also common, but rodents you should remember, because they might give a clue in the question in the future. When you appear for NEET examinations. Okay, patient is patient has an exposure to rodent urine. Okay, or else they can give you there are many rodents around the area where the people are living, and so these kind of clues you should catch up, and leptospirosis will should be one of your differential diagnosis. Okay, so according to the epidemiology, okay, rodents are the most important reservoirs for maintaining the transmission in most settings. So you should remember this. Human infection usually results from exposure to environmental resources such as animal urine, contaminated water or soil, and infected animal tissue. Okay, if any of the persons is getting exposure to these kind of substances like animal urine or contaminated water or soil, okay, and infected animal tissue. I mean, as we have discussed, there are many cattle, okay, people, swine, dogs, okay, and horses, sheep, goats, okay. So usually people consume cattle and sheep and goats. So if the cattle, if any of the cattle is infested with the leptospira, so the patient might contact this infection. So the entry is portals. The portals of entry is abraded skin, mucous membranes, and conjunctiva. Okay, can also, I mean, if the person is swimming in fresh waters, okay, so if he has any cuts over his skin, so if the water is contaminated with the animal urine, so he can contract the infection. So this is how, I mean, there is the entry of the spirochete into the human body. Okay, what are the risk factors of the infection? So occupational exposure, okay, the main occupational exposure are these farmers and cattle, I mean, people who grow cattle, and you are exposed, continuously exposed to cattle, and ranchers, abattoir workers, trappers, veterinarians, loggers, sewer workers, you should remember sewer workers, okay, and rice farmers, pet traders, military personnel, and laboratory workers. So you should remember all these occupational hazards. So all these people can be at a risk of developing this infection. And recreational activities like freshwater swimming, as I told you before. So freshwater swimming, the water can be uh, I mean, contaminated with the animal urine from a, I mean, infected animal, and canoeing, kayaking, and trail biking. Okay, these kind of uh, recreational activities can be an risk factor for the infection in the endemic areas. Okay, household exposure like pet dogs, domesticated livestock, rainwater catch systems, and infestation with infected rodents. Okay, so household contraction of this infection can be through pet dogs, okay, and infected rodents. Okay, infestation with the infected rodents. Okay, you should keep in mind. And others are barefoot walking. Okay, if the soil is infected or with the animal urine or anything, and the leptospira can live for a long time in the soil. If it depends upon the pH of the soil, so you should remember that if the patient is walking barefoot, so if he has any cuts or sores or any ulcers on his foot, then he might actually take up the virus, okay, and can be infected. So skin lesions, contact with wild rodents, accidental laboratory exposure. So people who are growing, culturing this spirochete inside the laboratory are also at a risk. So healthcare workers who are working in laboratories, okay, so are also at a risk of developing the infection. Okay, so microbiology, coming to the microbiology, what does it look like? Okay, leptospira is a spirochete, as we have studied before. The known species, we have 22 species of leptospira. Okay, the 10 species are regarded as pathogenic here. Okay, the most common which we learn here is Leptospira interrogans. You should remember Leptospira interrogans is the one of the most common one. Okay, there are other 10 species, so you should also remember any of this can be given. So mainly Leptospira interrogans, but you should also remember the other 9 also. So it is a spirally shaped, highly motile aerobic spirochete. Okay, so in the examination you have to mention, when you're writing, so you have to mention this: it is a spirally shaped, highly motile aerobic spirochete. Okay, so this is the morphology, how it looks like. Okay, with 18 or more coils per cell. Okay, I have a picture of the leptospira, so I'll show you in the next slide. So it is best visualized by dark field microscopy, staining with a silver stain. Okay, and fluorescent microscopy. Okay, this is how you look for the leptospira. I mean, in the desired specimen which you have given. Okay, if you have collected blood or urine or cerebrospinal fluid. Okay, so all these specimens should be uh, looked for in dark field microscopy, stained with silver stain, and in fluorescent microscopy. They can be distinguished morphologically. From other spirochetes by their unique question mark hook. So this is one of the clue. Okay, in the NEET examination, you can be asked that there is a spirochete with a question mark, unique question mark, this thing. So you should be thinking about leptospira. Okay, so question mark hook at the end of the bacterium. So this is how it looks like. So this is how it looks like. See, the whole image looks like a question mark. So there is a hook kind of thing. Okay, so this is a spirochete. You have the 18, so how many 18, they have described 18 coils so per cell, and so this is how it looks like. It's a spirally shaped question mark type. Okay, highly motile. Okay. The pathogenic Leptospira species can be grown in vitro from clinical specimens, including blood, urine, cerebrospinal fluid. So, as I've told before, so if you want to look for the spirochete, you need to take these samples from the patient. Okay, and if you are suspecting leptospirosis, then you have to look for Leptospira in these specimens in the dark field microscopy with a silver stain. Okay, and a fluorescent microscope. Okay, special media for isolation. Okay, these medias can also be asked in the examination. So Fletcher's, okay, Ellinghausen, McCullough, and Johnson Harris. These EMJ is what they give. Okay, the full form of EMJ is Ellinghausen, McCullough, Johnson medium, or polysorbate 80 media can also be used for the culturing of the spirochete. Okay, how does the I mean, what's the pathophysiology? What we see here is the penetration of the tissue barriers to gain entrance into the body. Okay, and there will be hematogenous dissemination. Okay, this is how it enters the humans. Okay, and patients with severe leptospirosis have an evidence of cytokine storm. Okay, there will be a massive cytokine storm and inflammatory response from the body, and there will be massive release of when there is an inflammatory response, the body reacts to it, and it releases massive cytokines, which causes hypotension, vasodilation, fever, okay, tachycardia, and many other symptoms. Okay, so this you should remember, it can cause cytokine storm. Okay, what are the chief inflammatory mediators? What we are released are IL, interleukin 1, interleukin 6, and interleukin TNF. And in interleukin 1, 6, and TNF alpha. Okay, these three you should remember, and many other cytokines are also released. Okay, due to the inflammatory response. Okay, what is the clinical presentation? How does the patient present to you? Okay, most of the infections are mild in immunocompetent patients, and in also in many people who are immunocompetent also develop severe disease, but it totally depends upon person to person. So people who are affected, who are mildly affected, might not show up to the clinic or the hospital, but people with severe disease, okay, with jaundice and symptoms of sepsis and hypertension, high rate fever, and all, they show up. So how do they present? So the incubation phase of these incubation period of the leptospira is 3 days to a month. So in between these times, between these period, patient can present anytime, so you should be aware of that. So 3 days to a month is the incubation period, and sudden onset fever, chills, and headache are the presenting complaints. Okay, you can also have muscle pain, tenderness, common uh, commonly in the calves and the lower back. So you should be knowing this. Muscle pain is restricted and not restricted, but can be mostly in the calves and the lower back. There will be conjunctival suffusion and dilation of the conjunctival vessels. with purulent exudates. Okay, so you should also look for the conjunctiva and the conjunctival injection. So dilatation of the conjunctival vessels. There can be exudates also. Okay, there can be subconjunctival hemorrhages. Should also be looking for. Can present with uveitis. Okay, there can be non-productive cough. Can be icterus. Okay, so should be looking all these symptoms. So nausea, vomiting, diarrhea and abdominal pain will be there. Okay, there can be bleeding manifestations. Okay, in severe disease, will we call, if the patient is having liver and lung involvement, we call it as Weil's disease. So we'll be further discussing about that, I mean the severe, mild and severe diseases. So the dysfunction can be with multiple organs like liver, kidneys, lungs and brain can be affected with this spirochete. So you should be remembering all these. So what all we have here: fever, chills, headache, okay, muscle pain and tenderness, conjunctival suffocation and subconjunctival hemorrhages, uveitis, non-productive cough, icterus, okay, nausea, vomiting, diarrhea and abdominal pain, bleeding manifestations, okay, and multiple organ dysfunction. Leptospirosis has been described as a biphasic illness. Okay, there are two phases. The first phase consists of acute febrile bacteremic phase, okay, lasting for 2 to 9 days, after which there may be a period with little or no fever, okay, and apparent improvement. Okay, so in this phase, the patient is febrile, usually can last 2 to 9 days. So this is a bacteremic phase. So there is rapid growing of bacteria, spirochete in the body. So in this phase, there will be no fever. I mean, there will be little or no fever, but can be present because it's a febrile phase. So sometimes you cannot expect fever also in this phase. And in the second phase, it's an immune phase where the immune system reacts to the spirochete and develops antibodies and starts breaking down the spirochete. So it characterized by renewed fever and development of complications. So this is the phase where the patient presents with fever, high grade fever, chills and other manifestations, and can also be prone to develop complications. So you should remember this. So there are two phases. The first phase is a febrile phase, the second phase is an immune phase. Okay, for the exam purpose you need to write this thing, put it on the paper. So okay, regarding the biphasic illness of the leptospira. And during the immune phase, the leptospiras are absent from the blood but may appear in urine. So in the immune phase, because there is a breakdown and I mean the removal or the antigen antibody reaction in happening in the body. So the body might be clearing all the spirochetes. So in blood you might not find the leptospides, but definitely there will be leptospides in the urine. So what all complications do we develop in a patient with leptospirosis? So patient with jaundice and renal failure is called Weil's disease. Okay, as I've told before, jaundice patient, if the patient is presenting with renal failure and hepatic dysfunction, so this type of manifestation is called Weil's disease. Okay, there can be pulmonary hemorrhage. Patient might go into acute respiratory distress syndrome, as we have discussed uveitis as one of the clinical this thing, and optic neuritis and peripheral neuropathy, myocarditis, and rhabdomyolysis. Okay, these are all the complications that might be massive due to muscle breakdown. They can be rhabdomyolysis, myocardial involvement, and the irritation can cause myocarditis. There can be peripheral neuropathy, optic neuritis, and uveitis can be the complications. Okay, when we do some laboratory investigations and some imaging, what do we see? Leukocytosis and thrombocytopenia are common, but patients, they have many reports that the patients have been presented with pancytopenia. So you should also keep in mind the patient, you should not ignore and we should not rule out leptospirosis if the patient is presenting with pancytopenia, jaundice, renal failure. Okay, and pulmonary manifestation. So you should also keep in mind. So leukocytosis, thrombocytopenia are documented, but many case reports have shown that the patients have presented with pancytopenia in severe leptospirosis. Okay, so hyponatremia is one of the important feature, because hyponatremia is very common in severe leptospirosis, because the spirochete is the spirochete is involved in the renal ascending limb of the renal nephron. So the sodium potassium 2 chloride channel is altered, and so there will be loss of sodium. So that is a mechanism how the hyponatremia happens. So hyponatremia, you should remember, as one of the investigations where you can see in leptospirosis. Urine analysis shows proteinuria, pyuria, okay, granular gas, and can be hematuria also. So there will be definitely elevated urea and creatinine uh, in the renal function tests, and minimal to moderate rise in the hepatic transaminases. So when ALT and AST can rise, okay, up to 10 times or less than 10 times. So you should also keep in mind, so that you can differentially diagnose, okay, in other diseases also, and you should try to rule out and not to get confused with other diseases or any viral illnesses. So there can be mild to moderate rise in the hepatic transaminases, that are AST and ALT, and the total bilirubin can reach up to 60 to 80 milligram per deciliter. So if the patient is presenting with jaundice, so the bilirubin can rise up to 60 to 80 milligrams per deciliter. So you should also keep in mind that the high total bilirubin can be there in patients with leptospirosis, severe leptospirosis, or in Wheels disease, what we say. And a cerebrospinal fluid examination shows, because these patients are more prone to aseptic meningitis. So you should keep in mind that even the brain is involved in leptospirosis, so patients can present with meningitis. You should also keep in mind that the leptospira is one of the organisms which can cause aseptic meningitis. So you should not rule out leptospirosis in patients with some signs and symptoms of meningeal irritation. So, what kind of picture do we see in cerebrospinal fluid? A lymphocytic neutrophilic pleocytosis with minimal to moderately elevated protein. Okay, there is a lymphocytic picture or neutrophilic picture can be present, and there will be mild to moderate protein elevation. Okay, so there will be increase in protein, and there will be normal or low glucose concentration. So what all do we see in a cerebrospinal fluid? Cerebrospinal fluid, we see cell counts. We also see the protein, and we also see the glucose. So what type of cells do we see here? We see a lymphocytic or a neutrophilic picture. Okay, and protein concentrations can be elevated. Okay, there will be increased protein in the CSF, and normal or low. Many case studies have shown low glucose, but usually what the books give is the normal glucose concentration. But you should also keep in mind. So coming to the imaging, the chest radiography, if there is any pulmonary involvement, you can see small nodular densities, okay, which can confirm consolidation, and there can be ground glass appearance. Differential diagnosis. Okay, so this is very important. So differential diagnosis is the tricky part in this disease, because it is because the leptospirosis is involving many organs. So the many diseases show this kind of presentation. So you should always keep in mind that you know how to rule out all these diseases and how to reach our diagnosis. So malaria, dengue, and chikungunya fever, these infections where the liver is affected, and you can see pancytopenia or hematuria, okay, anemia, and elevated transaminases in dengue, okay, thrombocytopenia. So all these come as a very crucial part in diagnose, in difference and diagnosing case of leptospirosis. So you should always keep in mind and rule out malaria, dengue, and chikungunya. Okay, scrub typhus is also one of the things you should rule out. But scrub typhus can present with this kind of manifestation, but in scrub typhus usually you see lymphadenopathy. Okay, lymphadenopathy, and you should also search for an local eschar. Okay, where the mite has bitten the person. Okay, and so they should also search for a eschar and lymphadenopathy, and localized lymphadenopathy around the eschar is possible in scrub typhus. So we do not see lymphadenopathy in the leptospirosis, so you should rule out. And murine typhus and spotted fever also mimic symptoms with leptospirosis, so you should always keep in mind. And typhoid fever, of course, because typhoid is very common in India, the Salmonella typhi. So the step ladder pattern of fever, and fever with bradycardia and all, you should also look for, and you should also rule out the typhoid fever from the leptospirosis. Okay, hantavirus can cause renal and pulmonary syndrome. So in a patient with severe leptospirosis, there can be pulmonary involvement. I mean, the patient might go into ARDS, and there can be renal failure. So this kind of virus can cause renal and pulmonary syndromes. So you should also differentiate the leptospira from leptospirosis from the hantavirus kind of infection. And acute viral illnesses can also mimic leptospirosis. So you should also always keep in mind to rule out all these diseases, okay, to get to your diagnosis. How do you diagnose? There are several tests. Okay, the mostly followed is the IgM ELISA. Okay, and the RT-PCR can also be done. Okay, these are all the previous tests which were done. Okay, the blood culture, isolation of the organism, blood culture of the urine, blood, and also CSF can lead you to the diagnosis. And the microscopic agglutination tests, also called as MAT, can be done. Blood culture, immunofluorescence assays, polymer PCR targeting the 16S part of the ribosomal RNA gene can also be done. But the most commonly done is the serological test, where we see the IgM ELISA, enzyme linked immunosorbent assay of the antibodies developed against the leptospira. Okay, the antigen detection, direct antigen detection. Okay, antigen detection in the blood using monoclonal anti-LIP-L32 antibody based antigen capture ELISA can also be done. And the molecular tests are the RT-PCR, and the loop mediated isothermal amplification, which is also called as LAMP, can also be done in the diagnosis and to diagnose the leptospira. Coming to the treatment, most cases are self-limited. Okay, patients with mild infection might not show up to the hospital, and they can, the treatment is self-limited, so they do not require any antibiotics. So definitely we should start antibiotics in severe and diagnosed cases. So Jarrett's Hexamer reaction, this is one of the important terms you should be knowing about. What happens actually is, this can be asked in many examinations actually. So you should be knowing about this reaction. When there is a massive amount of bacterial load, as soon as you diagnose the case and you start antibiotics, the antibiotics act rapidly and break down the spirochetes. So these broken down spirochetes, they actually start a massive inflammatory response inside the body. So the patient can have immediate fever, rigors, and hypotension immediately after the antibiotic usage. So you should keep in mind about this reaction. So this is called as a Jarrett's Hexamer reaction. So what happens here is, immediately after the usage of antibiotics in the patients with diagnosed leptospirosis, so after the due to the immediate breakdown of the leptospira, after the antibiotic usage, these the broken down products, they create a massive immune inflammatory response, and they release massive cytokines, and patient will have immediate fever, rigors, and hypotension kind of symptoms. So you should keep in mind. So in mild disease, how do you treat the patient? You give doxycycline, okay, 100 milligrams orally twice daily for 7 days. Okay, in children, 2 milligrams as milligrams per kg per day in two equally divided doses. Okay, so doxycycline and azithromycin in the mild disease. Okay, so the treatment will alter in the severe disease definitely. So you should see if the patient is having mild symptoms, okay, and he's not gone into any complication. Okay, so since even then you have diagnosed leptospira, then you should use doxycycline or azithromycin. Azithromycin 500 milligrams orally once daily for 3 days. Okay, in children, 10 milligrams per kg orally on day 1, followed by 5 milligrams per kg orally once daily for subsequent days. Okay, so this is how you give azithromycin in children, and in males, 500 milligrams orally once daily for 3 days, and doxycycline is 100 milligrams orally twice daily for 7 days. How do you treat in pregnant women? Pregnant women can contract this infection because they're also at a risk. So 500 milligrams orally once daily for 3 days, or you can also use amoxicillin, because doxycycline is not used, it's contraindicated in pregnant women, so you should not give doxycycline in pregnant women. So azithromycin or amoxicillin can be used. Amoxicillin at 20 to 50 milligrams per kg body weight in 3 equally divided doses for 7 days, and azithromycin 500 milligrams orally for once daily for 3 days. Azithromycin is a preferred over amoxicillin if the differential diagnosis includes rickettsial infection, because many rickettsial infections, the treatment of choice is azithromycin. So if you're looking for any other suspecting any other rickettsial infection, so you can just avoid amoxicillin and just give azithromycin, so that if there is any other rickettsial infection also, it can be treated easily. So in severe disease, we give penicillin, okay, 1.5 million units intravenously for 6 hours for 7 days. Okay, this is a treatment for severe disease. You can also use doxycycline, ceftriaxone, or cefotaxime. Doxycycline 100 milligrams IV twice daily for 7 days. Ceftriaxone 1 to 2 grams IV once daily for 7 days, and cefotaxime also 1 gram intravenously for 7 days. So penicillin, doxycycline, and ceftriaxone for 7 days is usually preferred in severe disease. You can also prolong the antibiotic course if there is no improvement. So usually 90% of the patients show immediate response in severe disease, and you should also symptomatically treat the patients. I mean, you should also take precautionary measures if the patient has developed any organ failure. So regarding that, but the mainstay of the treatment is antibiotics to remove the infection. But you should also, if the patient has already gone into complications, you should also, I mean, if the patient has gone into liver failure or renal failure, or the patient has developed meningitis, should also take precautionary measures. Okay, what and corticosteroids have been the magic drugs, what we say, in many of the diseases. So is there any role of corticosteroids? But I mean, many studies have shown that yes, there has been a role. Okay, but not frequently used. But if the patient is showing vasculitic nature in severe leptospirosis, then corticosteroids have a role in the disease. So disease treatment, what we say. Okay, so regarding the treatment and the prevention, how do you prevent leptospirosis? Prevention measures include avoiding potential sources of infection, administration of prophylaxis for individuals at high risk exposure. Okay, so better to stay away from the infection and to to get to avoid these kind of things. So animal vaccination is one of the mainstay to better to not get animals contacted and contaminated with this infection. So animals, because it's a zoonosis, is transmitted from the cattle. So to keep the places and the surroundings clean, so that the rodents to avoid to rodents, so that if the places are dirty, if there is any left out food, if the rodents come to feed, and so this can be a potential risk of how people contract the infection. So vaccination of the domestic and farm animals against the leptospirosis can provide variable levels of protection. So this has been uh, done in endemic areas. So vaccination is one of the mainstay in prevention. And there have been many studies. Okay, people who are going into endemic areas, so doxycycline 200 mg every week for 2 to 3 weeks for people traveling to endemic areas is one of the prophylactic treatment uh, for the leptospira, to avoid the leptospira infection. So we should also remember this. So doxycycline 200 milligrams every week, and prevention, avoiding the potential sources of infection, and administration of prophylaxis for individuals high risk exposure, prophylactic antibiotics, which is doxycycline, and then animal vaccination of the domestic and farm animals is one of the preventive measures which we take in leptospirosis. So we have come to the end of the our disease treatment prevention. So we'll go for a quick recap. Uh, some main points. So this is a zoonosis, and it has many diseases. Has so many disease names. Which I mean, it's also called Wheels facile. You should also remember. So leptospirosis is a zoonotic. It has the tropical climates are more 10 times higher than the temperate climates. So you should also remember that. Mammals are the natural hosts. Rodents are the most important reservoirs, maintaining transmission in the most settings. Human infection is due to the exposure of the environmental sources. Okay. The portals of entry are cuts or abraded skin, mucous membranes, and conjunctiva. Risk factors: occupational exposures, recreational activities. Okay. So household exposures from rodents. Okay, and barefoot walking, we should also remember. So 22 species, 10 are pathogenic, visualized by dark field microscopy or fluorescent microscopy with a silver stain. And morphologically, there's a question mark hook of the bacterium. So this is how it looks like: question mark hook kind of thing. Can be grown in this media, Fletcher's or EMJ media or polysorbate 80 media. So can produce cytokine storm. Okay, penetration will progress to hematogenous dissemination. Then incubation period is for 3 days to a month. Okay, fever, chills, headache, muscle pain, tenderness, conjunctival suffocation, subconjunctival hemorrhages, uveitis, non-productive cough, icterus, nausea, vomiting, diarrhea, abdominal pain, bleeding manifestations, okay, and multiple organ dysfunction. Also, biphasic illness, two phases: febrile phase and immune phase. Okay, immune phase usually have fever and complications. In febrile phase, they might or might not be fever, but usually last 2 to 9 days. Many complications, as we have discussed: optic neuritis, peripheral neuropathy, rhabdomyolysis, acute respiratory distress syndrome, and pulmonary hemorrhage. Leukocytosis with thrombocytopenia, hyponatremia is which you should remember uh, because due to the uh, involvement of the sodium potassium 2 chloride channel inside the loop of proximal convoluted tubule and loop of Henle, and elevated urea creatinine, a transamine, moderate raise in transaminases, bilirubin, high total bilirubin, and a neutrophilic and a lymphocytic pleocytosis, high moderate rise in protein concentrations, normal or low glucose in the CSF. Consolidation with ground glass appearance can be there in chest radiography. Differential diagnosis very important. Malaria, dengue, chikungunya, scrub typhus. Also rule out typhoid, hantavirus, and other viral illnesses. Diagnosis is with microscopic agglutination tests, culture of the specimens like blood, CSF, urine, immunofluorescence assays, polymerase PCR of the 16S RNA gene, and serology IgM ELISA to leptospira. Antigen detection of anti-LIP-L32 antibody based antigen. Molecular tests are PCR, RT-PCR, and LAMP, loop mediated isothermal amplification. Treatment self-limited sometimes. Already discussed about the Jarrett's Hexamer reaction. Okay, mild disease, we give doxycycline 100 milligrams, azithromycin 500 milligrams. Either of these can be given for 7 days, and doxycycline for 7 days and azithromycin for 3 days, 500 mg orally. Okay, pregnant women never treat with doxycycline, always azithromycin or amoxicillin. If you are suspecting any other rickettsial diseases, can give azithromycin because it will treat either of the disease. So severe disease, penicillin, doxycycline, and ceftriaxone. Okay, for 7 days, penicillin 1.5 million units IV, doxycycline 100 milligrams twice daily, ceftriaxone 1 to 2 grams, and cefotaxime 1 gram for 7 days. Corticosteroids if the patient is showing any vasculitic type of picture. Prevention to avoid the potential sources, animal vaccination, prophylaxis with doxycycline, 100-200 milligrams every week for 2 to 3 weeks if the person is traveling to an endemic area. So that's it for today, students. Thank you so much. Hopefully, you will be able to answer any type of question regarding leptospirosis now. So I think you don't have any doubts. I mean, everything was clear. So leptospira, last time we have discussed leishmaniasis. So we'll be discussing another topic next week. Thank you.